Good evening, everyone. Welcome again to the Innovation and Precision Eye Health Webinar Series 2023. Let me introduce myself first. I'm Dr. Tam Yi Chong. I'm an assistant professor at the Ophthalmology Department, Yong Yew Ling School of Medicine of National University of Singapore. I'm also the Optometry Education Program Director for the newly launched Center for Innovation and Precision Eye Health at our Yong Yew Ling School of Medicine. Now, for those of you who have attended our launch in person, we have successfully launched our center on the 25th of March. Once again, thank you for coming and thank you for your wonderful support. And after our center launch, today marks the first webinar that we are having post-center launch. And today it's my great honor to invite my good friend and also a world-renowned researcher, clinician in myopia. And he is Associate Professor Jason Yam. Let me introduce Jason a little bit. So Professor Yam is an Associate Professor from Chinese University of Hong Kong. He's also the Undergraduate Division Head at the Department of Ophthalmology and Visual Sciences of Chinese University of Hong Kong. As some of you may know, and in fact, I think most of you know that he is a leading pediatric ophthalmologist and a highly prolific researcher, particularly in myopia area worldwide. He's also the director of the COHK Jockey Club Myopia Prevention Program. He has multiple papers, more than hundreds, and he's the PI of landmark myopia control trials, the LAM studies, and a landmark children cohort study, the Hong Kong Children Eye Study. And today, his funding has exceeded 100 million Hong Kong dollars, and I am feeling a little bit envious by saying this. Yes, Hong Kong, $100 million. And today, his numerous awards include the Asia Pacific Academy of Ophthalmology Nakajima Award, which is highly prestigious, the Hong Kong Humanity Award 2021, and also the prestigious George Warman Memorial Lecture, which is conferred by the International Myopia Conference. Now, just to put things into context, so for Professor Yam to speak, normally we will have to attend overseas conference. We have to travel and to hear him share his findings from his landmark trials and studies. But today we are very fortunate that we don't have to travel overseas, and yet we have the privilege of inviting him to be our speaker for today's webinar series. And I can say for sure we're in for a treat, because today it's accumulation of all his past experience and achievements accumulated almost 1 decade in myopia research. So without further ado, I shall hand the floor over to Professor Yam. Jason, please.
Thank you, Yi Chong. Thank you. It's my great honor to be invited in this webinar. And thank you very much for all your very kind introduction. I'm truly honored. And I hope today I can, sorry, here is again, let me, do you see the screen, or is it in the?
Yes, it's okay. Yep.
It's in the slide mode. It's
yes.
Screen mode. Okay. So it is truly my honor. And so today what I'm going to do is I hope to share with you some of our findings on myopia control and prevention based on the Hong Kong Children Eye Study and the LAM study. So I have no financial interest to disclose. And myopia, as we understand, it is a global prevalence is increasing very rapidly. And the complication of myopia is significant. In this review paper, it suggested that the risk of having MMD, the myopic macular degeneration, is more than 800-fold comparing those without myopia in the lifetime. And therefore, the prevention of myopia is important. And today, I would like to focus on the Hong Kong Children Eye Study, which also include the Hong Kong Children Eye Genetic Study, some of our findings, and also the LAM study. Basically, the approach is we have children cohorts, which to look into the lifestyle, risk factor, prevalence, and also the genetic. And also we have using some clinical trial to determine the intervention. So the Hong Kong Children Eye Study was started in 2015. So it is about 8 years ago. To start off with, the first phase, the scale is a little bit small. And so on every weekend, we invite children to our clinic. Why it is a weekend? Because in the weekdays, the children need to attend the school. And why don't we go to the school? Because it is difficult for psychometric examination, and also while inviting the children come into our clinic, we can have a more detailed examination. We can do whatever we want to examine. And so it is already now is the third phase, and coming together along since 2015. On every weekend, we invite the children and their parents to our clinic for eye examination and also intervention. So now roughly more than 40,000 children and their family has been included. So in every weekend, we do a comprehensive eye examination and also detailed questionnaires, including the parenting style, FFQ, allergy, mental health, etc. And also the lifestyle, including the reading habits, the outdoor time, all this will be captured. And the eye examination, including the psychometric reflection, corneal biomechanics, anterior segment, posterior segment, OCT, fundus picture. Some of them will do visual field. And also we collect the biosample, including the blood. And this is the so far we established a children eye biobank based on this cohort and also with some of our interventional trial. And we are very fortunate in the past few years, we published about more than 40 publications, including we are very fortunate to have obtained some of the funding from charity trusts, from the Hong Kong Jockey Club Charity Trust. We are truly appreciate for their support and donation, and also through our research grant. But our research funding grants in Hong Kong is not large, is not a big funding, I would say. But we are very grateful to all the support from our funding agency. And we evolved this program as kind of a territory-wide campaign, and also we are very fortunate to have got some society recognition, society award. So some of the findings I would like to highlight today is to talk about the myopia. So from our study, we look into the myopia pattern in Hong Kong. We have looked into 3 areas. One is the pre-COVID era, during the COVID, and also the post-COVID era. So before the COVID, we published our first report in 2019. So the data in the age of 6 is about 12%, age of 7 is 24%, age of 8 is already 36%. It's very, very high. And during the COVID period, we understand the lifestyle has been changed and myopia progression has been increased, has been demonstrated in a few reports. And during that time, we also look into what are the myopia incidents in Hong Kong. So especially at that time, there is a school closure in Hong Kong from January 2020 to September. We have quite a long time of school closure. And also, so what we do is we call back some of the children, because it is a launch, because we have all weekend, we have the children coming back. And so we can have the baseline data just before the COVID. So we call back 800, 700 of them after 8 months. And also before the COVID, we have a 3-year follow-up cohort is ongoing. So we compare these 2 cohorts to look into the myopia incident, the progression data, and also the lifestyle changes. We found that there is a significant lifestyle changes during the COVID. The outdoor time has reduced significantly from 1.3 to 0.4 hour per day. And also the screen time in particular is a significant increase from 2.5 hours to 7 hours per day during the COVID. And therefore, we look into the estimated annual incidence. It is a 2.5-fold comparing to the pre-COVID. So it is an alarmingly significant increase in the myopia incidence. And the estimated annual change in the progression is also double, and also the axial link elongation is 1.5-fold increase. And the lifestyle changes during the COVID time, in fact, aggravate the already very severe burden of the myopia, and therefore we really need to do something to help our next generation. And now the COVID has gone. I think I should say this. Then COVID, even in Hong Kong, we are now mask free in most of the places, and the restriction has been lifted. And we want to answer a question: what are the prevalence after this? And the lifestyle, whether the lifestyle changes return back to normal, or are there any risk factor affecting the myopia in this? So what we do is we look over, we review over the past 7 years myopia data in our children cohort, and we want to identify whether the pre and during and post-COVID, what are the things. So it is a repeated cross-sectional study. And we look into about 2000, because we have, it's not up to date yet. The data was captured in 2021. So we included 20,000 children, 6 to 8 years old, and all has the psychoplegia reflection and the axial link and also the lifestyle questionnaires. So 2015 to 2019 is the before the COVID, and 2020 is the time where most of the school closure happened. And after 2020, in 2021, we resumed gradually the face-to-face classes, physical lessons. And what we see is, in fact, from 2015 to 2021, to 2015 to 2019, the myopia prevalence are very stable all along. But in 2020 and in 2021, it increased. And it is also correlated with the SE and also axial link pattern. And the outdoor time and screen time, in fact, in 2015 to 2019, the outdoor time is relatively stable from 1.4 hours all the years. But in 2020, it decreased significantly to 0.8. In 2021, it is good that it has increased back, but it is not returning to the pre-COVID level. Same in the outdoor time and the near work time. It is increased in 2020 and it reduced a little bit, but it hasn't been reduced to pre-COVID level. We noticed that the outdoor time and the near work time hasn't convert back or return back to the pre-COVID era. And we also do the association between the period and also the myopia prevalence. And we found that the longer duration of the COVID pandemic exposure, and also the low-income family, and also parental myopia, and the young age is also the risk. So to summarize, the lifestyle changes including increased digital learning, persist beyond the COVID school closure. And myopia increase in children during the pandemic and will be sustainable, will be sustained even after the restriction was lifted in Hong Kong. So these are particularly affected in the young children, younger age group, and the low-income family. We are meaning that for these two groups, the change from pre-COVID to the after COVID, the differences in the change is more significant. They are become more vulnerable due to the this new era. And so we need to highlight these two groups and to help them. And another point, another finding in the children's study is about the reading distance. So another paper is in about 2,300 children. We use a video to capture the reading distance of the children, a 9 minutes video. And then what we do is we look into the reading distance and their myopia rate, and we found that the reading distance, the shorter reading distance, is in fact really associated with more myopia, and also the habitual reading distance of under-corrected children, in fact, were shortest comparing to those non-myopic children, and also the fully corrected children. And so based on video recording to document the actual reading distance, the reading distance was shorter among the myopic children with undercorrection. And the reading distance less than 20 centimeter, it is a 1.7 risk fold increase in risk myopia. And therefore, myopia undercorrection should not be recommended because in fact, it will shorten the reading distance and also increase the risk of myopia. And another factor we want to look into is the parental myopia. So in 6,200 children, we included around 2,000 family trio, meaning that one children and both parents are included in this study. And we have their actual SU length, actual refraction, and to do the analysis. And we found that out of parental myopia, parental education, time outdoor near work, in fact, the parental myopia status is the strongest risk factor. And you can see that when both parents are highly myopic, in fact, the risk of myopia is 12 times higher. In fact, it is a dose-related effect. You can see if it is a moderate to moderate myopia is fourfold increase. High myopia and high myopia is 12 times increase. And also with age of onset and parental myopia, in fact, we can quite good to predict the risk of having important indicator to predict children's myopia development. And another area we have looked into in the children cohort is the genetic. And this slide that I have shown before that we built our children eye biobank. And so far, we have published a few reports about in relation to myopia, the PASIX gene, FSH1 gene, are associated with extreme myopia, but not low-grade myopia. And ZC3H and BICC1 gene are also a genetic risk factor for moderate and high myopia. And we also look into the progression cohort. In 3 years, we found that FHS1B, KCNQ5, GJD2 are also risk factor for myopia progression in children. And we are also looking at doing some GWAS in our children, and the data is completing, and we hope that we can share with you more about our finding about the GWAS data in the children cohort. Interestingly, in fact, based on our children cohort, apart from myopia, we also look into other factors. Some of the factors that can be highlighted is that one of them is astigmatism. In astigmatism, we report, in fact, in Hong Kong, there is quite a high prevalence of the astigmatism in Hong Kong children, up to 21% in the refractive astigmatism and 63% in the chronic astigmatism. And another paper recently published is about, again, using a trio family trio, that we look into 5,000 trio children and also 10,000 parents together. And we found that, in fact, parental astigmatism is the most important factor associated with the child astigmatism. And so it is suggesting that for those parents, if both parents are highly astigmatic, we need to the early screening for children astigmatism should be targeted for those of parents with high level astigmatism to provide timely detection and intervention to prevent amblyopia. Another factor we have been looking into is the secondhand smoking. Secondhand smoking, we based on our questionnaire, we document the number and also the duration and the exposure of the secondhand smoking. One of the paper we published is to look into the secondhand smoking and the choroidal thickness. And then we found that the exposure to secondhand smoking was associated with a thinner choroid, suggesting that the harmful effect of secondhand smoking on the children's eye. So this is one of the first report on this area. And subsequently, we also noted the secondhand smoking exposure is associated with a thinner retinal nerve fiber layer in 3,000 children. And recently, which will be published soon, we look into the secondhand smoking and the myopia using 12,000 children, and we confirmed that the secondhand smoking exposure, in fact, is associated with myopia in children. And in particular, the younger the children's age, and the greater the association between the secondhand smoking exposure and the children's SE and the SU length. In the children cohort, we also look into some ocular imaging marker. Among them, one of these is OCTA. We are glad that our paper published in 2018 is one of the first paper to report the demographic, not the demographic of the OCTA in children, and then we look into the OCTA metrics with the amblyopic eyes, and using a population-based nested case control study in 1,000 children. Among them, 30 of them are amblyopic, and then to do the comparison, we found that in fact OCTA, the OCT angiography matrix is also affected in the amblyopic eyes. Our data supports the presence of the macular microvascular abnormalities in amblyopic eyes in children. Of course, the retinal vasculature, we are also doing some more analysis in this. One of that, we look into the effect of high blood pressure, obesity in the retinal vasculature. And recently, we have published also the brush membrane opening minimum rim width, the BMO, the MRW, in the children. And also the recent paper is on the peripapillary gamma zone in 1,200 children. We found that in fact the peripapillary gamma zone is not just occur in the myopic children, it also occur in non-myopic children, although their characteristic and distribution were substantially different. So these are just some highlights that based on our children eye study, we have tried to explore the data in various aspects in terms of the myopia area, astigmatism, other ocular disease prevalence, the secondhand exposure, other area, and also the imaging, trying to contribute to the understanding of the children's ocular health. So the second part of this webinar, I would like to share with you about the LAM1 and the LAM2 study. The prevention and control of myopia. In fact, I would say there is a four main way to control the myopia: the increased outdoor time, optical method, such as the defocus spectacle, contact lens, ovokeratology, pharmacological method, the atropine, and also the recently emerging the red light therapy. And so my talk will mainly focus on the atropine study and mainly focus on the finding from the LAM studies. So in fact, a lot of wonderful work has been done on the atropine by our colleagues from our dear colleagues from Taiwan. They use a lot of atropine drops from various concentrations. And of course, I have to mention that the importance of the interest of the low concentration atropine are really based on the landmark Singapore ATOM study, the ATOM 1, which confirmed 1% atropine is working, and also the ATOM 2 study, which bring it into the interest of the low dose atropine to the world. However, there are some remaining questions after the ATOM 2 study. What are the efficacy compared with the placebo? Are there any concentration dependent response? What are the optimal concentration? Are there any effect on the cornea and the lens power? What are the factors associated with the treatment response, any biomarker? Should we continue the treatment or should we stop the treatment after 2 years? Are there any rebound effect? What are the longer term efficacy, and can atropine delay myopia onset? So we started the LAM1 study, the low concentration atropine for myopia progression study, in 2016. We are fortunate that it is the first RCT on low concentration atropine compared with a placebo. We use 430. We recruit 438 children and receive in 4 groups 0.05%, 0.025%, 0.01%, and the placebo group. And this is we have reported phase 3 result. We are going to finish submit the phase 4 report, which is a 5-year report, but up to now we reported 3-year results. So we have reported a few papers based on the LAM study. So the first year report, it is based on a comparison with the placebo. Number one, we demonstrate there is a clear concentration dependent response. 0.05, 0.025, 0.01%, and placebo. This is SE progression, this is SE link elongation. Comparing to the placebo group, 0.05% can achieve roughly 67%. And 0.01%, it is quite concentration dependent. You can see 0.025 is about 43%, 0.1% is about 27%. And of course, there is a change in the accommodation pupil size. The change in accommodation is about 2 diopter loss in the 0.05%, meaning that for our children, roughly they have a 12 diopter in the accommodation, and they have lost 2 diopter, they have a 10 diopter in the mean accommodation. Their reading distance has to lengthen from about 8 centimeter, the closest reading distance to maybe 10 centimeter or 12 centimeter at most. So they need to lengthen a few centimeter, which is still acceptable because our reading distance should be about 30 centimeter. So most of the children using low concentration doesn't complain of any blur near vision. The pupil size has increased about 1 centimeter in the 0.05%, whereas in 0.01%, the change in pupils are about 0.5 millimeter. But the accommodation amplitude change hasn't been too much in the 0.01%. So the need of photochromic glasses, progressive glasses, hasn't been changing. It's not it's not significant difference among the group. Photophobia at 2 weeks is particularly higher in the 0.05%, but after 1 year, most of the children will get used to it, and then the photophobia rate is not significantly differences. And we also document the vision-related quality of life in all groups, which are also similar among all the groups. So in the first year report, we demonstrate there is a concentration-dependent response. And in the second year report, we continue the treatment group to the second year. And the placebo group, we have to switch over to 0.05% because we have demonstrated it is effective. For the ethical concern, we switch over to the 0.05%. Here you can see that in fact the concentration-dependent response remain over the second year. The reason of doing the second year is that in the ATOM2 study, and there seems to be a significant better effect during the second year for 0.01%. So there may be a suggestion, or there's some discussion whether in the second year or longer term, the lower concentration 0.01% will become better with a much better efficacy. But in this second year report, we see that the concentration dependent response among the 3 groups remain, and roughly 0.05% the efficacy comparing to 0.01% is double. You can see over 2 years the efficacy is progression is -0.5, and 0.01% is -1.2. And the switchover group, when you use 1 year placebo and then you switch over to 0.05%, the effect is similar to the 0.01%. So the concentration dependent response remain. 0.01% atropine in the second year is mildly more effective in the second year, but it's not significantly more effective comparing to the first year. But that doesn't occur in the 0.05% and 0.025%. One of the reasons for the more effective, my postulation or my belief is because the very low concentration with time, you will accumulate more effects. So maybe the lowest concentration with time, the efficacy will be better. Whereas in the 0.05, 0.25, the effect seems to be already plateaued during the first year. So it won't become much more effective over time. Of course, if you think about in this way with the older age, of course, all the effectiveness will be increased. But when we do a comparison here, in fact, 0.01% is mildly more effective during the second year. And the efficacy of 0.05% atropine observed was double that observed than 0.01%. And also, there is also a discrepancy between the effect of the SE progression and the SE length. You can see that the SE progression seems to be better, the efficacy, comparing to the placebo, comparing to the SE length. So there has been a discussion whether the distinction between the refractive error and the SE length data, is it related to the change in the corneal curvature or change in the corneal power? And this is important because we want to understand whether the anti-myopia effect of atropine, low concentration atropine, is via the SU link elongation or associated with other associated biometric changes. So in another report, we look into the ocular biometric study to look into the other factors, including the corneal power, lens power, and anti-chamber depth. Here you can see that, in fact, the change in the SE is concentration dependent. Change in the SU lane is also concentration dependent, but the corneal power, lens power, and anti-chamber depth are similar across all the groups. So there is no differences among all the groups in the corneal power and the lens power. In this model, you can also see that, in fact, the SU length contribute to about 70% to 80%, whereas the remaining contribution to the SE variance is by the SU length, lens power, and corneal powers. Therefore, number one, SU length alone only contribute to the SE variance about 0.7 to 0.8. And also the children's SU length elongation is also include the normal age-related growth, although very small. It is not completely parallel to the SE changes. Therefore, the change or the efficacy of the SE progression and SU length will not be completely parallel. So in summary, for this report, low concentration atropine has no effect on the corneal power and the lens power. The contribution to the SE progression is mainly from the SU length. The corneal power and lens power in each atropine concentration and placebo were similar, and therefore the anti-myopia effect from atropine is mainly reduced via SU length elongation, and it is important because it can reduce future risk of myopia complication. And another question we want to answer is, are there any factors associated with the treatment response? Therefore, we can adjust our treatment protocol or treatment strategy. And so we look into the baseline factor. This is a secondary analysis of our 2-year result from the LAMP study. So age, gender, baseline SE, outdoor activity, parental myopia status, treatment compliance, near work, among all this, only age is significant factor that determine the treatment response in the SE progression and also in the SU length elongation. Here, you can see it is a graph showing you that, in fact, this is 0.05%, 0.025%, 0.01% placebo group. The older the age, the better treatment response in all the group. The younger the age, the poorer the treatment response in all the group. Interestingly, if we, in this pool analysis, we look into age 4. If you are using 0.05%, in fact, it is similar to a child age 6 using 0.025%. It's similar to age 8 years old using 0.01%. It's also similar, I haven't shown here, to our children age 10 using placebo group. So in fact, this report demonstrates, in addition to the concentration dependent response, there is in fact an age dependent effect. The younger children require a higher concentration in order to achieve a similar efficacy as older children on lower concentration. And therefore, when we see children with young age of onset, say for example, age 4, age 6, very young onset, in fact, a higher concentration should be administered because the progression will be faster. The treatment response must be poorer comparing to our older children. A higher concentration should be administered as a starting dose for young children. And also, are there any biomarker for the treatment response during the treatment period? We look into the OCT of the LAMP study, and then in fact, here's the 0.05%, here is the 0.025%, here's the 0.01%, and the placebo group. In fact, you can see that, in fact, the atropine can induce a choroidal thickening effect. And the choroidal thickening is also concentration dependent. And in the mediation analysis, we assess that, in fact, the choroidal thickening also contribute to a direct effect and indirect effect, have about 20% effect of the SE progression rate. And the low concentration atropine induce a choroidal thickening effect along a concentration dependent response. Throughout the treatment period, the choroidal thickening was associated with a slower SE progression and SE length elongation among all the treatment groups. The choroidal response can be used as an assessment for long-term treatment outcome and as a guide for concentration titration of atropine. And in the third year report, we want to look into answer 3 questions. Number 1, should we continue the treatment or should we stop treatment after 2 years after the low content atropine? And also, what are the long-term efficacy compared to the 3 groups? And what are the rebound? What are the risk factors for the rebound? Are there a lot of significant rebound? Especially this happened in the ACTOM-1 study, where 1% atropine after you stop the treatment, there is a significant rebound, limiting the long-term efficacy of using the eye drops. So what we do is during the 3rd year, at the beginning of the 3rd year, we randomize each group into 2 parts. One part is continue the treatment. One part is to stop the treatment, to do the washout in each group into half and half. So here you can see number 1, over 3 years time, continue treatment of 0.05, continue treatment of 0.025, and continue treatment of 0.01%. The concentration dependent response remains 0.05% better than 0.025, better than 0.01%. And the switchover group, here is the switchover. We keep the switchover group all along. And number 2 is you continue the treatment, compare you do the washout. In fact, in each concentration, continue treatment do better than do washout. Meaning that if you are doing the 3rd year, we still suggest that you continue treatment because it will confer a better treatment effect when you better than you stop the treatment. And number 3 is to the rebound. Here you can see that the rebound. In the rebound, we look into the factor associated with the rebound that is in the washout group. 2 factors are related. Number 1 is the age at the treatment cessation. Number 2 is the treatment group. Number 1 is the older age that you stop the treatment, the less the rebound. Every 1 year later that you stop the treatment, it accounts for 0.08 diopter less rebound for that. And the higher concentration, in fact, it will have a more rebound. 0.05% is more rebound than 0.01%. But 0.025%, the rebound is not significant comparing to the 0.01%. However, even though the rebound is concentration dependent, but look into the actual data for 0.05, 0.25, 0.01, the rebound magnitude compared in the 3 years is not clinically very significant on that. So our 3rd year report, we suggested that we need to continue the treatment during the 3rd year to achieve a better effect. 0.05% atropine remain the optimal concentration over 3 years in Chinese children. Stopping treatment at an older age at a lower concentration is associated with a smaller rebound. The differences in rebound effect were clinically small across all the 3 studied atropine. All concentrations are well tolerated. We suggest using 0.05% atropine into the 3rd year in the Asian children. And the final part I would like to share with you our LAMP2 study. LAMP2 study is to answer 1 question. Can low concentration atropine drop 0.05%, 0.01% prevent or delay myopia onset in children? We have, in fact, we have started the LAMP2 study in 2017. So it has been about 6 years or 5 years to complete this trial. It takes a very long time. And so it is first RCT placebo control on atropine delaying the myopia onset. We recruited 474 children with into 0.05%, 0.01%, and placebo group. And So the primary outcome, we look into two primary outcomes. Number one is cumulative incidence of myopia. That is, for those children, either one of the eye become myopic, minus 0.5 diopter, and in one of the eye, we count it as incidence of myopia. But you can, for those children included in this study, all are without myopia. Their range is plano to 1 diopter hyperopia within this range. And they have parental myopia. One of the parents will have a minus 3 diopter myopia. And then you can see that just for cumulative myopia incidence, some may think that it may not be completely fair, because the range from to become incident myopia for each children is different. So we also look into the percentage of participants with fast myopia shift, meaning that for those of them with at least 1 diopter myopia shift in one of the eye was counted as a fast myopia shift. So of course, secondary outcome was included into the SE progression and SE lane elongation in all the group over 2 years time. So we included 3 groups and in 1:1:1 ratio, and the baseline of these 3 groups are no significant differences. And so this is to see that you can see the placebo group 0.01% and 0.05%, almost in all the follow-up period. The incidence myopia is significantly less in the 0.05%. This is a 0.1%. This is the placebo group. And for the 2-year myopia incidence, 0.05% over 2 years, 28.4%. In the 0.01%, it is 45.9%, and the placebo group is 53%. And the fast myopia shift rate, 0.05, is quite similar to the myopia incidence. The 0.05% is 25%, 0.01% is 45.1%, and placebo group is 53.9%. So there is a significant lower myopia incidence and lower fast myopia shift rate over 2 years time in the 0.05% atropine group. And here is the secondary outcome in terms, we look into the SE myopia shift and also the SE length. Also, we can see that the 0.05% atropine, the SE progression is 0.49 diopter, 0.01% is 0.84 diopter shift, and placebo is 1.1 diopter. So again, there is a significant lower SE progression, SE lane elongation over 2 years in the 0.05% group. The side effect, we look into the use of the photochromic glasses, progressive glasses, photophobia, allergic conjunctivitis, or all the group do not have a significant variation, significant difference. So it is the first 2 years RCT placebo control on low concentration atropine on delaying the myopia onset. 0.05% atropine, but not the 0.01% atropine, can reduce both the incidence of myopia and the percentage of children with fast myopia shift. And the efficacy is roughly about 46.7% relative reduction. And comparing to the outer activity that published in the JAMA 2015 in Guangzhou cohort, every 40 minutes per day over 3 years, the relative reduction is about 23% in the cumulative myopia incidence. So 46% to 47% relative reduction is by far, I would say, to reduce the myopia incidence onset is the most efficacious. So using atropine is now the most efficacious in preventing the myopia incidence or preventing myopia onset. There's a good tolerability in 0.05 and 0.01% without adverse side effect. So I think I have to finish. So this is the take-home message for the LAMP studies, and I would like to acknowledge the funding agency, because we really indebted to a lot of different funding agency for the support, in particular the Hong Kong Jockey Club Charity Trust. And I would like to thank my department, the whole team. It is a whole teamwork in order that we can achieve, although it's not a lot, but we can achieve something to contribute. And I would like in particular to thank my mentor, Professor Kelvin Pang, Professor Cameron Tam, for their truly amazing and tremendous support since my academic career in 10 years ago. And I would like to thank my partner, Professor Chen Lei Gai, Dr. Gam Gawai, and Ms. Mandy Ng. We all work together on all these cohorts. So I would like to thank you once again, and thank you, Yi Chong, for and also thank you our dear friends in Singapore, all the support and sharing. I still remember the time that I come to you and Professor Cheng Yu and in a cafe to chat about some inspiration on different idea how to make use of the data. So I really appreciate the friendship and also the support from Yi Chong and also the team. So thank you very much.
Thank you very much, Jason. What a wonderful talk. One of the best that I personally have seen in many years, to be honest. One of the best. It's a huge combination of your children cohort study and also the trial studies on the atropine treatment, and not just atropine treatment for myopia progression, and particularly in your recent LAMP2, you have shown evidence that 0.05% can efficiently delay myopia onset. I think that is what makes it remarkable, and which is why deservingly in JAMA, published in JAMA. So now comes to the exciting part, which is the panel discussion and the Q&A session. I would like to invite our audiences who are online to put up your question in the Q&A box. If you look at the bottom of your Zoom, there is a Q&A box. Feel free to type in your question there. As we start having questions rolling in, perhaps I will get started first. And of course, before we begin the panel discussion, I would like to also invite my dear colleague, Dr. Sun Chen-Xing, who is a pediatric ophthalmologist consultant at our National University of Singapore and National University of Hospital. He is also a myopia expert, and I'm very glad that he is joining us today for this panel discussion. So Jason, so now given all the evidences that you have amassed over close to 1 decade, and may I just ask you this broad question just to peel in the crystal ball a little bit. What is the future direction there? It seems like you have done a lot, but at the same time, there's still a lot of unanswered questions. So for us to learn from you, what should be the specific research questions, directions that we can potentially focus on moving forward?
I'm humbled that for your questions. In fact, I think there's still many for us to do, because by far, for example, 0.05% atropine or even higher concentration, it can only achieve about mostly up to 70%. But still, it is not. It still have 30% progression. So if we can do something that can increase the prevention, I mean, increase the efficacy of the prevention, then imagine if we can have a combined therapy or some therapy that can reduce the myopia progression up to 85% or more, then I think we don't have high myopia in future. Then that should be the way. So I think combining various methods to try to increase the efficacy for preventing myopia progression. Number one is progression, and also preventing the myopia onset will be one of the particular importance especially in children myopia field.
Thank you, Jason. Actually, my next question, I would like to open to both Chen-Xing and yourself. As you know, I'm also into health services research, and as with all new treatment or new innovation, we often also look into patient acceptability, and in this case, not just the patients, but also the parents. So I would like to have your personal view. So given that, for example, from LAMP2 study, now 0.05%, it's efficient with good efficacy. From parents' point of view, is that enough to convince them that starting on this would make them feel assured that it will successfully or efficiently delay myopia onset And at the same time, as we know that this is a long-term commitment, and so when it comes to communication with patient and the parents, how best should we communicate this? And they will often ask, when should the treatment stop? And now that you have observed the rebound effect, so does that mean that they have to continue the treatment all the way until, for example, adolescent age, 17 or 18 years old? So how do we manage this patient acceptability component here? So over to you, Jason, and maybe later on, Chen-Xing.
Me first.
Yeah, Jason, go ahead, please.
Okay. Thank you. So for the of course, for treating myopia using atropine or all the other methods, the communication with the parent and also involvement of the parent is very important. But I think in Singapore and also in Hong Kong, the parents' characteristics are similar. So they are very committed. They are really committed, and they are really committed to help to reduce the myopia for the kids, because the kids' progression is really fast. So say, for example, for the myopia onset, for using to prevent myopia onset, of course, I would say we are targeting on high-risk group. What the high-risk group? Number one is parental myopia. So if both parents are highly myopic, number two is young age, 4 years old, 5 years old. Number three is the hyperopic reserve. The hyperopic is only minimal. If a person with both highly myopic parents comes to us and only age 4 or age 5, and only say, for example, plus 25 plus 0.25 diopter hyperopia, I would say the case is becoming myopia in 6 months. And then the parents will also understand, and that's the time whether we intervene or not. We still analyze some of the data, but you understand when you become myopia, the progression is much faster. It's completely different when you before that you are not myopic. So so that's important, that if we can catch the time to intervene timely. But if our parents is both not non-myopic, the children is already 9, 10, still have plus 0.5 diopter, I won't give the jobs, even though they request, because and also they will not be committed because they are not convinced and they do not see the problem. So I think we are targeting on some high-risk group. And for stopping the treatment, I would say many parents do not want to stop the jobs. Instead, even though I ask them to wean off to stop the jobs, they say they are still tolerating well. They don't see the reason. I would say yes. Based on the phase 3 reports, we are suggesting that number one, we stop at an older age, and then we wean it off. Will help to reduce the rebound, and also this should be the way to stop it. What are the age? I am not sure yet. We are still looking at the data. I suggest probably after age 14 to 15, because about that time, usually the myopia progression rate is much reduced.
That's well said, Jason. I think the key thing and the uniqueness of your papers and findings is you have both the children cohort study to support the evidences generated from your trial. So very insightful. Chen-Xing, anything to add on from you?
I agree completely with Jason. Yes. I think most of the parents in Singapore are very accepting for atropine treatment. I think we have a big proportion of children on it, and a lot of parents know about this treatment and come in asking for it. So when we mention to them, they are very accepting. Regarding the tapering, I think there is still a lack of evidence on what is the best way to taper. There are people that reduce to lowest concentration first before they reduce the frequency to every other day instead of stopping abruptly. I don't know what's Jason's practice for tapering off, but I think there needs to be a better study to figure out what is the best way to taper off atropine.
Thank you. A lot of questions in the Q&A. Perhaps I will help to moderate a few. There are a few questions which I think both your answers previously have already addressed those. So I will focus on other questions. We do have quite a good number of optometrist friends and colleagues joining us in this webinar as well. So there are a few questions pertaining to combination treatment, low dose atropine and with optical modalities, for example, contact lens and the myopia control lenses, which combination would work best? So thoughts from Chen Xing or Jason? Maybe Chen Xing, you can go first.
Yes, there is a synergistic effect when combined the optical modalities with atropine. I think there are several publications that have showed this synergistic effect, and the theory is bigger pupil size from the atropine enhance the optical effect from your optical designs. So I think it makes sense. And for me personally, I will recommend the myopia control spectacle first. Either the Hoya Myosmart or the Essilor Stellus. These are the two that have been proven to work. And then if they still continue to progress, and there is the other option of the Johnson & Johnson Ability Daily Soft Lens, as well as the Cooper Vision MiSight. So these are all methods that have been proven to work on randomized control trials. Yep.
So just to add on, very good answer from Dr. Sun. And these are purely based on his clinical experience. So we have no financial disclosure to make here. Jason, how about you?
Yes, in fact, I think the combination therapy should be the way, because if you are a parent using for the kids, you understand this by no means you use a single treatment. Most of them, if they have want a more complete control. Although evidence are not a lot, but combination therapy, as Dr. Sun has mentioned about, in fact, combining atropine with OK lens has shown some synergistic effect with more data coming out. And other optical method, I'm not quite sure about the true effect yet, but still in Hong Kong we are quite common to use combination therapy with the defocus spectacle. Whether it is combined with a contact lens or keratology or defocus spectacle, it really depends on the parent's modality choice. And but I think combination therapy should be the way forward.
Very good. So there's also another question. What about the effect of atropine for the various doses beyond 2 years? Have you have evidence on that already? I believe I can answer for Jason. To observe or report the effect of atropine beyond 2 years, probably we have to invite Jason to come back next year and to see whether he has more findings to add on 3 years, maybe next year when you come back and give this talk. Is that correct, Jason? This is ongoing.
Yes. We are for you mean for the LAMP2 study is still ongoing. For the LAMP1 study is also still ongoing. So we still don't have a more longer term data yet. We are still learning from what we gather about the data. And we are really hoping that we can share with you more updated data once it is available.
So of course, this is a very precious Asian-based data set. And there's also a question in the chat which refers to the CHAM trial. The CHAM trial in the Western country. So given that Jason, your expertise in this area, compared to the CHAM trial, what are the findings that you have found in your study which is different?
I think in Asian and in European or in the Western, the major differences is the progression rate. In fact, why there is an age-dependent effect, one of the major reasons is because of the progression rate. When we come to a treatment in a fast progression trial cohort, the efficacy is reduced. In a slow progression cohort, the efficacy is increased. So therefore, in the LAMP2 trial, even we expect the efficacy is much better, but because of the COVID, all the progression, the incidence myopia shoot up, and therefore the efficacy become turning down. But in the Western country, I would say in the Western country, the progression cohort is slower. The whole population, the progression rate is lower. So I would say the concentration dependent response should remain, but a lower concentration may be enough for the Western country. because lower concentration can achieve similar effects in a slower progression cohort comparing to a higher concentration in a fast progression cohort. So this is my view.
So there's another question on supplements. For example, supplements with bilberry. Maybe get views from Chen Xing on this. Any evidence on this?
Unfortunately not. Singapore has also a birth cohort called Gusto study. And Prof. Saw Xiang Mei actually has worked with me and others to look at vitamins level and various supplements level in this birth cohort of children to see whether is there any dietary patterns that contribute to myopia progression or any vitamin deficiency of any sort. And we did not identify anything from that birth cohort of about 1,000 children. So currently there's no evidence to my knowledge that it says any supplement that can prevent myopia progression. How about Jason?
I think yes, there's not much evidence on using dietary supplement, except in Japan there is some trial ongoing is using the quercetin, a kind of supplementary supplement that has shown some mild effect, very mild effect, and I can see that now that this kind of supplement is on the market. But I would say the evidence still need to be verified using a large cohort, and also the efficacy, the effect size is not strong.
So Jason, speaking of that, in your cohort study, did you manage to capture data on supplement intake?
Yes, we have the FFQ and we have some supplement data, and we will look into that on so far we do not find any really effectiveness on myopia progression.
So by far, this is the webinar which we have received the most questions. So in the interest of time, I think I'll just leave it to the last two questions. Okay, the next one. Of course, one of the side effects of atropine is that it affects the amplitude of accommodation. And this question is pertaining to accommodation insufficiency after they stop the treatment. So in addition to the rebound concern that you all spoke about, how about accommodation insufficiency after stopping atropine treatment? Have there been any cases or any evidences on this so far?
I personally do not have any experience on that, and I am not very fully aware of any reports on having the accommodation insufficiency after stopping the treatment, and on that.
All right.
Yeah, okay. I'm not aware of it.
The long-term data, in fact, we need to learn from Taiwan. Our colleague from Taiwan, they use various concentration from 1%, 0.1%, 0.5%. Still they haven't reported very long-term decades data yet. Based on our LAMP study, it's still only 7 years. So I'm still learning from what the data that can tell us.
I think the ATOM study, 5 years study, didn't show any long-term accommodation effect, but that's only after 5 years.
Excellent. Perhaps just one last question. Of course, now given all the wonderful evidences and can further guide clinical practice in this area, how about cost? And of course, this is a long-term treatment modality, and of course, cost is always a factor to be taken into account as well. So just your personal view, how do you see the trajectory of the cost for atropine treatment? How can it become a little bit more affordable, or maybe now it's relatively affordable, but how can it be even more affordable, even more scalable going forward, especially in Singapore and Hong Kong? Your thoughts, please.
I think for Singapore, we are quite blessed that it's subsidized by the government. So patients can get subsidy from government to purchase atropine. But I think going further forward will be involving the subsequent follow-up care of these patients in the community optometrists. so that these patients don't need to come to hospital just to get atropine and their myopia control. I think that's the way forward to bring down the whole cost of treatment. Yeah. So I would like to be in touch with all the optometrists in the community. Yep.
Thank you, Chen Xin. Jason.
I think in Hong Kong, so far now the atropine is only available in the private market. So we are still learning, and we are hoping that the Hong Kong government will also cover the cost for that. We are working. Every one of us in Hong Kong are working on how we can benefit more underprivileged or those children in need. So we are still working on that, how to bring down the cost and make it become more cost effective.
Thank you, Jason. Well, I think wonderful responses, which is why we have exceeded 6 minutes. Let me conclude by first thanking Dr. Sun Chen-Xin, my dear colleague, for being a wonderful panelist with us today. And of course, our wonderful speaker, Professor Jason Yam. We have learned a lot from you. And as I said right from the start, this will be a treat for us. It's indeed a treat. And I feel like I have garnered much more knowledge over the 1 hour compared to all the papers that I've read. So I have to thank you for all the teaching and sharing. Thank you once again, Jason.
Thank you so much for your